single three-dimensional problem. So I will show you a few cases just to let you understand what it is about the projection. You can see here in this case the projection is caused by the lateral crura excess length, probably even the too much septum support. In this case as well we have big lateral crura and tip is supported by the septum. In this case it seems that the tip is too long, but actually the problem is not the tip, it's the septum. So this means that actually this tip is, I don't want to say under-projected, but probably normal projection. In this case we have a lot of septum and also a long lateral crura. In this case we have a long medial crura, okay? So you can see that probably it's not a problem of septum. So this means that we have intrinsic tip support and extrinsic tip support. So about the intrinsic, we can say that the tripod concept is totally right. I mean, long medial crura, long lateral crura, but we have to consider also that for the intrinsic support we have soft tissue envelope, which means skin thickness and ligament thickness. Sometimes we have excessive SMAS, too much SMAS, okay, that here can give support. While about the extrinsic, we have septal support, so we have caudal septum length, anterior septal angle strength. We saw today with Aaron that you use C-graft when the Wasa segment is weak. And also anterior nasal spine can be hyper-projected and can give you extra projection. And also soft tissue envelope, which is the periosteum and mucosa. Sometimes mucosa excess can give too much projection. So this is the intrinsic, which is the lateral crura and medial crura. And you see when I rotate the flap, the extrinsic comes out and gives you more projection. About the rotation, we have here as well intrinsic and extrinsic. So for the intrinsic, it depends on the medial crura and lateral crura length. So that's why we play with lateral crura still and medial crura over here. For the extrinsic, we have something that creates a push counter rotation, which is the upper lateral cartilage, and we have something that gives you rotation, which is the caudal septum, and or for example septal extension flap. So this is, you already know everything about the ligaments. I want to show you this case. For example, if we analyze the anatomy, you can see that the lateral crura is actually not too long. Is the septum is pushing, so I'm planning to make a low septal sweep to bring this torsion down and to give a rotation to the tip. And as you can see, look the difference. TSTI is here, while when I finish the surgery, TSTI is exactly over the Wasa. Okay? So, of course, all those factors play together and then you obtain a result. So in the last years I changed many times technique because I was not happy about my result. And I was using columnar strut as a projection technique, but we realized that we need something more strong to support. Tonkin groove is too strong, so we were trying to find the balance between those two techniques. So I realized after many failures that I need to control the anatomy with a good support. If I have a good support for the tip, the rotation doesn't change in the postoperative time. The Wasa is the main factor that maintains the load of the tip, the weight of the tip. If the interdomal ligament is intact, The cartilage quality is very important. If it's weak, it's not going to work. And thin skin and thick skin patients is totally different, because thin skin patients, whatever you do, even just a columellar strato, maybe not in this one, will stay. But this thick skin patients is a big problem. You see in South America they use a lot of septal extension graft, and this is the reason. So I need to find a technique which guarantee a precise positioning of the tip over the wasa segment. If I don't rotate the tip, I'm obliged to extend the wasa segment with the septal extension graft. What I want to say with this, I will go there to explain this point because it's very important. So, if I have my dome, this is the longer cartilage. If my dome is here, okay, you see there is nothing under the dome, so this tip will go down. So you are obliged to extend the wasa with a septal extension graft to give support. Instead of doing this, we like to do lateral prastile because we like to shorten this distance. So we do lateral prastile, and we also make rotation of this flap. So this comes like this, and at the end you will find the dome not here but here. And so you will have the support of the wasa. So it depends a lot on your style. If you like short noses, I mean the length of the dorsum, then it's much better lateral prastile. If you like another style, it's much better septal extension graft. Sometimes it's not the style, sometimes it's the case, sometimes it's the face of the patient. If the patient is a short face, lateral prastile is better. If it's a long face, I think that septal extension graft is better. So you have to change your technique according to the case. Don't oblige all the patient to one technique. So let's take a picture about this. This is how I change technique according to the case. So thin skin patient and good cartilage quality, I try to fixate intrinsic factor with polygon tip, extrinsic factor with septal extension flap plus membranous tongue groove, and dome repositioning over the wasa segment. If I have thick skin patient, bad cartilage quality, or when I need extra push, then I do. For the intrinsic factor, always polygon tip, but for the extrinsic factor, I like to do septal extension flap plus membranous tongue groove with a modification of the tachograft to make a strong wasa segment. And of course, remember all I said about caudal septal trimming, dead space closure, upper lateral cartilage. As you see, I always do the same, like yesterday. So, this is what I do, as I showed you yesterday. After I make hip dissection, I cut. In this case, I was cutting the interdomal ligament, but yesterday I showed you that you can preserve it and use like a hand to hang over the wasa, but in this case I was opening it. And probably it's a mistake, because I'm leaving something that I can use as a support, okay? But to start, if you want to start this technique with this approach, maybe it's better because you have more space to work. So I access the caudal septum from here. I divide the membranous septum, and then I use the dissector to enter in the subperigonal plane. Try to go a little bit faster, already all of this, and you will have the video of the As you see, I dissect, and then from here I do my septal dissection. And this is, for example, one case where I have long intrinsic factor and long extrinsic factor. So you see very long nostril. So what I did, polygon tip to fix the intrinsic factor, and to fix the extrinsic factor, I just did repositioning of the tip over the vasa segment, and I will show you the video. Look, here I have the ligaments, and basically what I can do, I can grab the vasa and I grab the intercrural ligament, and I just oblige this ligament to stay over the vasa. In this way, I'm sure that the tip cannot drop, because this cannot drop and cannot counter-rotate. Impossible, because I create a blocking point. Okay? Try to do a little faster. You see, I suture it, and then I put it inside, and then you see the medial crura is kind of doing a setting, and you can put exactly at the level you want in a membranous spinal fashion, and this was the result after 6 months. You see how short becomes the dorsum, and short also the tip. This is another case. You can see she has a hump. She's very strange case because the bone ends here. So actually, I was expecting to find the rhinium here, but it was not. So it was the cartilage that was having a curve. The rhinium is here. So in this case, I wanted to give an extra push to the tip, and I had to make a double cut on my quadrangular cartilage flap, which is something really rare. But for her, I want an extra push, so what I did a mini taco. So it means that you do all the tip as I showed you before, but you want also to give more strength to the vasa. So you take these two small grafts and they hug the vasa and the caudal septum, you put inside, but the trick is this. You first suture to the dome. You see, I'm suturing the graft to the dome. I'm not fixing to the caudal septum, just the needle is keeping the graft in position for a moment, just to make this good reconstruction. Then I remove the needle, I put the tip inside, and then I choose exactly where I want my tip. I want more rotation, I want more projection, I want more counter rotation. Then when I decide where I want it, I fix it, I put again a needle, and I suture the graft to the caudal septum. Okay, my tip is gonna be maybe a little bit harder, but I don't care, because I want to be sure that this tip is not gonna move, and I want my result forever, let's say. Okay? And then after it, I finish my tip in a classic polygon way. Okay? So my take home, this was the result. You can see I have a better ratio. I was able to extend the infralobule. So my take-home message is don't use just one technique, but analyze the patient and do